So let's look at some clinical cases in medical biochemistry. My name is Dr. Onos once again. Question 1 says, a 28-year-old final year student went on an empty stomach to the gym this morning to work out. After working out for up to 2 hours, he decided to take a drink. Instead of drinking water, he drank up to 3 bottles of an alcohol-containing drink. So the hallmark here was that he drank alcohol. Few minutes after he slumped and died. Putting the incident surrounding his death into consideration, what could have been the cause of his death? So let's look at it here now. So the first thing to understand is that as he drank alcohol, he had not eaten. He drank alcohol. So a lot of metabolism for the alcohol produced a lot of NADH. NADH. Alcohol is metabolized in the liver by the activity of the enzyme alcohol dehydrogenase and to form acetaldehyde, which further gets dehydrogenated also to acetate. So there's increased NADH production due to alcohol metabolism. So this decreased NADH production will actually prevent the ability for him to actually undergo gluconeogenesis on this next slide now. Ideally, since he has not eaten, the body, the liver especially, would use pyruvate to synthesize glucose via the process of gluconeogenesis. But see what the problem is now. But since there's increased NADH level due to alcohol metabolism, the reaction would not favor this reaction this way. Instead, the reaction would favor these guys. This part will be favored more because the NADH increase instead will pick up the pyruvate and make a lot of lactic acid, as well as the NADH will pick up a lot of DHAP and make a lot of glycerol 3-phosphate. Now, the cause of this guy's death in this question was because of the increase in NADH converted a lot of pyruvate to lactic acid, lactate. And don't forget, he just exercised, he went to the gym, so there's already an increased load of lactic acid inside of the bloodstream, coupled with alcohol consumption now that raised levels of NADH and pyruvate being converted to more lactic acid. So there will be more lactic acid actually produced. So this patient actually died of what is called lactic acidosis, reducing the pH of the bloodstream, denaturing enzymes and proteins. This was all the reaction that was happening in this guy, which then led to his death. Let's look at question 2 now. Question 2 says, Mr. Ahmadi is a 65-year-old farmer who produces gari for a living. So note, he produces gari, so definitely he will be drinking a lot of gari at this age of his life. So who was rushed into the emergency unit this morning with a blood pressure of 190/120 mmHg. This is hypertensive emergency. The house officer on duty or on call quickly gave the patient IV nitroprusside, but gave it quickly. Question A says, what possible complication may result from the quick administration of nitroprusside? Question B says, what part of the electron transport chain would be affected by the complication? And question C says, what drug must be given as follow-up to reduce the potential complication? So let's check it out now. So this is the question again. I want you to note this. Now, nitroprusside is a drug given for hypertensive emergency, but nitroprusside is metabolized to cyanide. So this is the write-up here. This is extracted from our lecture notes now. It says that cyanide is a deadly poison because it binds reversibly to cytochrome AA3, that's complex 4, that's cytochrome AA3, that's complex 4, preventing electron transfer to oxygen and producing many of the same changes seen in tissue hypoxia. So look at the sources of cyanide now. It's gotten from burning polyurethane, that's foam stuffing in furnitures and mattresses. So if you walk in a place where they burn a lot of foam from mattresses and furnitures, you're going to expose yourself to a lot of cyanide toxicity, which will block complex 4, preventing oxygenation from occurring, and invariably there will be no ATP synthesis also. So, and also it's gotten as a byproduct of nitroprusside, the drug that was given, released slowly, and we need to give thiosulfate, can be used to destroy the cyanide toxicity. So the question says, what possible complication may result from the quick administration of nitroprusside? The patient may have cyanide toxicity. So what part of the electron transport chain will be affected by the complication? Is that you say cytochrome AA3, or you could also say complex 4. So the two of them are the same thing, the cytochrome AA3 or complex 4. Then the third question says, what drug must be given as follow-up to reduce potential toxicity? The answer to this would be thiosulfate. Thiosulfate should be given to this patient to prevent the toxicity of cyanide poisoning. So this is the answer to question 2. Let's move on to question 3 now. Question 3 says, there are two questions here. Patient A is a 57-year-old male who has been on long-term management of gout. His urine sample collected this morning showed high levels of hypoxanthine and xanthine. Explain the reason for the urine findings in patient A. Patient B, on the other hand, is a 35-year-old female who has never been diagnosed of gout, hence have not been managed for gout. Her urine sample also showed high levels of hypoxanthine and xanthine. Explain the reason for the findings in patient B. So let's go again. So patient A now, understand the metabolism of purines, the degradation of purines. Purines are degraded to hypoxanthine, and hypoxanthine and guanine mainly, even adenine, but most of the times we'll limit to hypoxanthine and guanine. And guanine is converted to xanthine. Hypoxanthine is also converted to xanthine, and xanthine to uric acid. So what is gout? Gout is excessive production of uric acid. That is gout. So if a patient has gout, what we give as a drug is we give allopurinol, which inhibits the activity of xanthine oxidase, the enzyme that converts hypoxanthine to xanthine and xanthine to uric acid. So if this enzyme is inhibited, there will be a lot of accumulation of xanthine and hypoxanthine as seen in the patient A. So the patient A has increased levels of hypoxanthine and xanthine because of what? Treatment with allopurinol. So giving this patient allopurinol because the patient has gout led to the increased levels of hypoxanthine and xanthine in the blood and subsequently in the urine. So let's go over to patient B now. So let's clean this up and explain why patient B actually has increased xanthine and hypoxanthine levels. So for patient B now, patient B says a 35-year-old lady who has never been diagnosed of gout, hence have not been managed for gout. Her urine sample also showed high levels of hypoxanthine and guanine. Explain the reason for the urine findings in this patient. This patient likely has deficiency of this enzyme called xanthine oxidase, not inhibited by any drug. It was not drug that was given. She has deficiency of xanthine oxidase enzyme. The condition here is called hereditary xanthinuria. So in hereditary xanthinuria and treatment with allopurinol, you're going to have increased levels of hypoxanthine and xanthine. But the hallmark difference between these two is that in the patients being treated for allopurinol, the enzyme is functioning well, xanthine oxidase is functioning well, and there will be part of the history the patient is on allopurinol or febuxostat, and that's another drug that inhibits xanthine oxidase. The patient B, on the other hand, has xanthine oxidase deficiency, which led to the increased levels of hypoxanthine and xanthine. So this will be the solution to the questions. Thank you, guys. So after filling the opt-in form where you write your name, your email, and your phone number, so upon clicking on Get Access, just quickly check your Gmail. You'll get a mail containing the lecture snippets and the 200 plus MCQ review. So once you open the message, you're going to get access to the entire content. So thank you very much. I'll follow you guys up on WhatsApp and via emails. Have a great time.